Good evening, everyone. I'm sure I've got some regulars on the call. For people that haven't had a webinar with myself, my name's Stephen Marks, Senior Lecturer in Mental Health Nursing. I'm a mental health nurse, sort of qualified over 10 years now, and I'm trained advanced practitioner as well. So really excited to talk to you about eating disorders tonight. It is quite jam-packed. I expect we'll probably be going right up to 9 o'clock with this one. But I'm certainly happy to, do the questions at the end as well. But yeah, there was just so much to cover. So it is, as always, a whistle-stop tour. I think that's the kind of caveat. It can't be as in-depth as I would have liked. But certainly, I think, if there's appetite for looking perhaps at the other eating disorders in more detail, do let the team know, and I'm sure that's something that we can look at. So tonight we're going to have a bit of an overview, some of the stats just to set the scene. We're going to cover the various types of eating disorder that you might come across. And I'm hoping as well that we can look at some of the myths around eating disorders, because I think it's perhaps one of the most misunderstood psychiatric conditions. In fact, a lot of people perhaps don't recognize that it is a really severe psychiatric condition. So I'm hoping that you'll come away with a bit of a fresh perspective. And I'm also going to signpost you to some guidelines that I think, anyone that's working in kind of certainly acute settings where you might come into contact with someone with an eating disorder, these guidelines really need to be on your radar. So, eating disorders affects about 1.25 million people in the UK. And the main kind of charity that supports people with eating disorder, that does a lot of advocacy, a lot of advice and support and resources, is BEAT. So I would encourage you all to have a little look at their resources. It's also a really valuable kind of tool if you're looking after someone with an eating disorder. It's kind of patient facing as well as for professionals. This is a bit of a breakdown. Probably the one that you're likely to have heard of is anorexia nervosa. We've got one called ORFID, which we'll cover. We've got binge eating disorder. We've got bulimia, and we've got a bit of a catch-all, which is OSFED, which is sort of other unspecified eating disorders that don't quite fit into the kind of traditional criteria. And I think it's quite striking that that makes up almost half of cases. It maybe gives us a bit of an indication that if half of people with an eating disorder are fitting into the category that's not, the kind of traditional formal one, maybe those old categories aren't quite fit for purpose anymore. Maybe they are in need of a bit of a review. I think with regards to onset, we typically see this in adolescence, early adulthoods, but it has been seen in kids as young as 6. And although it's a little bit rarer, eating disorders in some cases can emerge in people in their kind of 70s, 80s. It's a bit kind of difficult to unpick, but it shows the onset of various metrics. So kind of having a very low weight for your age, or having episodes of binge eating. And you can see here the kind of peak is clustered in this kind of adolescent up to 20 years, and then it tails off the older you get. So a lot rarer. I think if you get to 60 and you've not experienced an eating disorder, much less likely that you will. And again, all of the metrics really tend to occur in this age group. In terms of the outlook, anorexia and bulimia can last for quite a long time. So anorexia can last for up to 8 years. Bulimia can last for up to 5 years. So quite complex conditions. If you compare that to something like depression, which, you can sort of resolve an episode of that within 6 to 12 months. Eating disorder is a bit more serious. Really striking fact here that anorexia has the highest mortality rate of any psychiatric disorder. And I think the reason for that is because you're taking a group where there's a lot of medical complications, and you're multiplying that with a risk of suicide as well. So really, really serious and really important that this client groups get, care, the earlier the better, really. I think the sooner we can intervene, that's a kind of principle that runs throughout all of psychiatry. Early intervention really does have better outcomes. Now, everyone's experience of an eating disorder will be unique, but these are some of the kind of broad experiences that people might have. So typically we will see kind of distorted cognitions, distorted thoughts, and that might start with a preoccupation with weight, a distorted perception about your body image, and there's usually some kind of preoccupation with food. So it's these three things in combinations, but of course it will be very subjective. Now, when it comes to food, people can have very difficult relationships with food. Some of the things that you might see are kind of obsessive calorie or nutrient counting. And that's kind of been exacerbated by the rise of, apps like MyFitnessPal, which is obviously great for most people who are trying to lose weight and track their food. But it can become a bit of an obsession for people with an eating disorder. We might see binge eating. We'll probably see some purging as well. A bit of a misconception is that binging and purging only occurs in bulimia. It's certainly characterized by that, but we can have binging and purging cycles within anorexia as well. Some people are perhaps prone to over exercise. Again, it all feeds into this kind of idea of needing to lose weight. And there's even a phenomenon in some people kind of micro exercising, where you will perhaps be talking to them even when they're in hospital and they will not stop moving. And that's just because they are constantly trying to burn calories because it's such a preoccupation. We might well see kind of people going to toilet after meals with the intention of purging. And kind of if people are prone to binging and purging, there might be kind of habits around concealing food so that that can be consumed later, perhaps when, parents, relatives, etc. have gone to bed. Now, just to give you an idea, if you are looking after someone with any one of these conditions, there are a lot of resources on Beat, as I've mentioned, but they will break down, excuse me, all of these conditions and have really good support and resources for professionals as well as patients. I think something to bear in mind really as we go through the next set of slides where we're talking about kind of some of the common experiences. Eating disorders are perhaps one of the most uniquely experienced thing for that person. No two cases will be the same. You might have someone with this set of symptoms completely kind of presenting differently to a peer in a similar situation. I think there is, again, a bit of a misconception that people with anorexia always look very, very underweight. But for a lot of their kind of episode, they may well have a normal BMI, particularly with kind of binging and purging, bulimia. They may not look like they've got an eating disorder. That tends to occur much later. And in fact, that's quite dangerous because a lot of those cognitions, a lot of those habits have become a lot more kind of entrenched. So the behavioral changes are often present far before you'll see the physical signs. By the time you're seeing the physical signs, that's usually when people are presenting to hospital and needing a lot more medical intervention. And just as a sort of kind of prompt as well, I'm sure most of our trained staff on this call will be aware of this, but students especially might want to note that the term anorexia on its own simply means a lack of appetite. So if you see anorexia in notes, it might well be that someone's just got a lack of appetite, maybe because of the treatment that they're on, because they're poorly. So that's a different concept to anorexia nervosa, which is the psychiatric condition. So always worth checking that, because a lot of clinicians will write that shorthand as well. So anorexia, serious mental illness where people are a low weight because they are limiting how much they eat and drink. And quite often they will develop rules around, what they can and cannot eat, when they're allowed to eat, and the amount of exercise that they will do to get rid of that. There may well be purging, as I said. Normally with purging, we think about kind of making yourself sick, but you can purge through excessive exercise, using laxatives. All of these are kind of methods of getting rid of the food that you have eaten. So weight and shape are a massive part of someone's kind of self-worth if you've got anorexia. And I think this is where you can get into those really obsessive patterns of checking your weight, checking, how much you weigh, looking at yourself in the mirror, or even going out of your way to avoid that because you don't want to be kind of reminded. And it's quite common for people who are admitted to eating disorder units that they will want to avoid scales and mirrors because they are so upset about the numbers and what they feel that represents. I think this is really what makes anorexia a psychiatric disorder. It's almost a delusion, the sense of self, the sense of their own body that these people have, that is so far removed from kind of what we would objectively see as someone who is very low BMI, very underweight. And it can be very, very difficult to alter this perception. And when we look at treatment, the kind of gold standard for treatment is psychological therapy. There isn't really a medication that works to reverse this or treat it. Because it's so ingrained in people's kind of thought patterns. So it's not like there's a quick fix, like antidepressants, antipsychotics. It really takes a full MDT approach to get people better. So as I mentioned before, you may well see some of the behavioral signs long before the physical changes. So it might be that people are kind of counting the calories excessively, missing meals, avoiding eating with other people, hiding food, etc. Almost trying to give the impression that they've eaten when they haven't. One of the things, cutting food into tiny pieces to make it less obvious that they've eaten little, to make the food easier to swallow. I think most generations will have a kind of cultural touch point for this kind of thing. I'm of the age that I grew up watching Skins. I don't know if anyone is of that similar generation. And there was an eating disorder storyline threaded throughout that. So we quite often see that reflected in soaps and films, etc. It's not always hugely accurate. But I think organizations like Beat offer guidance and support on how we portray that sensitively in media, and kind of report on it in the press as well. And as I mentioned before, excessive exercising, vomiting, misusing laxatives, all of this kind of purging behavior. Psychological signs, these are some of the common things that might be reported or observed in people with anorexia. It's that kind of distorted perception about their body shape or weight, thinking or feeling that they are much larger than they are. Quite often there can be a sense of denial or downplaying the seriousness of the problem. And that becomes quite difficult because often people struggle for years and years with this thought that, they don't quite recognize it as a psychiatric problem that you can get support for. And by that time, a lot of these thought patterns and behavior patterns are quite entrenched and difficult to reverse. Some of the physical signs, which are quite serious, and this is kind of later on in the disorder where we might see this, affects the whole body system, really. You're going to have a loss of libido, difficulty sleeping. You're going to be tired if you're not eating. You're feeling dizzy, stomach pains, constipation, bloating. And I guess if these physical health conditions become chronic, you are much less likely to be able to engage fully in employment, education, etc. So this is where it becomes a real psychiatric disorder, when we've got people kind of dropping out of society because of their condition. You might also see a kind of soft, fine hair all over the body. It's called lanugo. It's kind of a telltale sign of people in the later stages of anorexia. And of course, if you're not getting the appropriate nutrition, vitamins, minerals, your hair is going to fall out. You're going to be quite weak. You're going to lose your muscle mass. Massive effect on hormone levels. We'll talk in a little bit about the effect on potassium and sodium. That's really when it becomes life-threatening. And again, that can be as a consequence of purging. If you are being sick or kind of having diarrhea forced through laxatives, you're really going to be messing with your electrolytes. And, people with that severity of anorexia, don't realize that they are at high risk of sudden death through cardiac arrest. So that's why it's such a serious condition associated with high levels of mortality. Longer term still, we see people with a loss of bone density, so osteoporosis, erosion of tooth enamel. If you're being sick, the acid in the sick is going to rot away your teeth. You're eventually going to get infertility, difficulty conceiving, heart problems, weakened immune system. And if the anorexia or the eating disorder starts in childhood, you can delay the onset of puberty. That's how much it messes with your kind of endocrine system and everything else that's developing. So, anorexia can be fatal. So we really need to get people treated and seen as soon as possible so that they can make that full recovery. And again, just a bit of an overview. I'm not going to go into this, but it really is an all body condition. I think we quite often think about psychiatric disorders just as illnesses of the mind, but this one has huge consequences for everything that's going on in your body here. So bulimia, kind of separate to anorexia, and that it's more characterized by the binge and purge cycle. That tends to be the predominant feature that we see. And what people report is that when they are binging, it's not just like having a couple of bickies or, going back knowing you've been a bit overindulgent. People report a real loss of control when they are eating. It's like they can't stop. It's a bit like they've dissociated. They've got absolutely no kind of power to stop that binge when it is happening. This results in a really severe crash, psychologically and physically as well. If you think you've just put all of that energy, sugar, fat, etc., into your body, that's really going to mess with your blood sugars. So that kind of crash, emotionally and physically, results in a lot of distress, a lot of guilt, and then people report kind of wanting to purge as a way of getting rid of I guess, feeling very, very very full, but also getting rid of that guilt, that distress. So that's when we tend to see vomiting, laxatives, fasting, even, and exercising. So that's where, if you're looking after someone who's very unwell, you might even have to have kind of one-to-one with them, even to the extent of them going into the toilet. You would need the Mental Health Act to cover such an invasive intervention. But, I've been in situations like that, kind of in liaison psychiatry, where we have had to have people on one-to-ones because their next purge could kill them. So that's how life and death it gets, really. I'm not going to repeat all of them. A lot of the behavioral signs are quite similar. It's just really that you're probably going to get more of an emphasis on food, maybe hoarding food, collecting food, concealing food, and purging, going to the toilet after food to purge, really. The physical signs, again, very similar. These effects, kind of long term, are really going to take its toll on the body, but you're definitely going to get much more of the physical signs around teeth enamel wearing down. People can even develop calluses on their fingers if they're using that to kind of bring on an episode of vomiting. Stomach problems are, I guess, more common because if you're really upsetting your tongue by having lots and lots of episodes of sickness. I guess you're probably more likely to have acute electrolyte imbalance if you are purging regularly. And we also see really quite serious disruptions to periods, fertility as well, and of course, blood sugar issues. But whereas over time, someone with anorexia, because their emphasis is on really restricting calories and over exercise, their physical appearance will kind of deteriorate over time and they'll look very, very underweight. Someone with bulimia can actually retain a fairly normal appearance, and that's why it's quite difficult to spot people with bulimia even after time. It's usually the teeth that are that kind of telltale sign that gets noticed. Binge eating disorder is very similar to bulimia except there isn't the purge that goes alongside it. So it tends to just be the episode of overeating. Um, Kind of that same idea of not being in control of it, very overwhelming, almost dissociating, but without the purge behavior. And as you can probably guess, the difference there, whereas if you've got something like anorexia and you are losing weight over time, if you're not purging, then you're going to have very similar health consequences to just eating unhealthily generally. So, weight gain, type 2 diabetes, heart disease, high cholesterol, obesity, hypertension. So, just as serious, but a different direction to bulimia and anorexia. Now, ARFID is, I guess it's relatively new that it's been recognised or certainly considered in the same discourse as anorexia and bulimia. But this is avoidant restrictive food intake disorder. Now, this is more about people avoiding certain foods, avoiding maybe certain textures, maybe having rules around things not being able to touch on the plate, for example. Now, I think if you go back 10, 20 years, these people would have been labeled perhaps fussy eaters. And what we are seeing more and more of is that ARFID tends to be more dominant in conditions like autism, OCD, and ADHD. Now, what makes this slightly different is that it doesn't really come with the cognitive distortions about weight or body image. So it's not seen as a full psychiatric disorder, really. It's not considered within the NICE guidelines on eating disorders. And I think the dialogue is this is more about disordered eating rather than an eating disorder. It's about the rules around the food itself, not because the person fundamentally has concerns about their weight, body image, etc. And then OSFED, this is what we referenced at the start, it's other specified feeding or eating disorder. So it's a bit of a catch-all. I think it was introduced as an attempt to have a framework to support people that didn't meet the full diagnosis. Now, historically, eating disorder services have had really strict criteria, and it's been based purely on BMI and weight. And what can happen, or what has happened for a very long time and still does, is that people will be excluded if their BMI is not low enough. And now I think I've always been quite, I think that's problematic. I think if you're already working with someone who's got issues around body image, what that almost translates to is that you are not skinny enough, your BMI is not low enough to warrant care and treatment. And I think when you have such a kind of a strict cutoff based on one metric alone, you're going to exclude an awful lot of people from care. And I think BMI itself is a bit controversial. You've got people who are listed as overweight or obese, but actually it's because they're super muscled. So we know as healthcare professionals, it's not a perfect metric by any means. So I think OSFED really has been introduced to try and support people who don't meet those quite strict older definitions and diagnostic criteria. So some examples might be like a binge eating disorder of low frequency or limited duration. So it maybe doesn't take over their whole life, but it's still a problem. Or kind of maybe someone's purging without the binge. Maybe they are eating a lot at night, but without the very severe kind of cognitive distortions or kind of long-term health problems. So treatment, as you probably guessed, eating disorder teams are very, very specialized, and it really does need a full MDT approach. As I mentioned before, there's not one specific pill or psychiatric medicine that is licensed to treat eating disorder. Yeah, if someone's got comorbid depression or anxiety, an SSRI or something might be helpful, but it's not actually treating the eating disorder itself. Really, long-term psychological interventions can be useful to help people cope with their feelings, understand the relationship with food, education around nutrition, maybe identify less harmful alternatives. But a lot of it is about forming or making new connections with relationships with food, being able to eat around other people. For people that have hidden their eating habits for years and years, it can be very difficult. You can feel a lot of pressure, feel very self-conscious, even just to eat a meal with someone. It's something that we take for granted. And a lot of the work that they will do in eating disorder units will just be therapeutic meal times, which might last several hours. And a condition of that is that you have to kind of eat that meal, fully get your calories and your nutrients, etc. So very, very difficult for people. And some people with eating disorders really resist the treatment because it's so psychologically difficult to do. That's why we see a lot of people detained under the Mental Health Act for that. So again, normally your psychiatrist is going to have to liaise with medical colleagues to address any associated physical health issues, so electrolyte imbalance, diabetes, blood pressure, and bone health. Now, my background, as I think I said, is in liaison psychiatry. So a lot of my experience and expertise doesn't come from working in inpatient units, but for kind of working with people when they've been very medically unwell. And that tends to be what happens. If you think you are going to avoid, you don't want to be admitted to an eating disorder unit under any circumstances. Quite often what happens is you get so poorly that you need medical attention, and you're then transferred to the psychiatric eating disorder bed when you become medically fit. And I've worked with patients that have been admitted for weeks, if not months at a time, because you get so poorly. A lot of treatment, just because resources are quite scant depending on where you live, a lot of treatment will occur at home or via outpatient clinics by psychologists or by psychiatrists. But it's that very unwell group of people that might need specialist inpatient treatment, and that may or may not be under section. Now, application of the Mental Health Act is very complex in this area. So normally, you cannot use the Mental Health Act to enforce treatment for his physical health issues. So if someone had dementia, you couldn't use the Mental Health Act to give them a brain scan. If you suspected a bleed, you would use the Mental Capacity Act. But in the case of eating disorders, you can use the Mental Health Act, and sometimes you have to do very invasive things like, supervising the toilet, restraining, force feeding, nasogastric tubes. Obviously, at that point, it's got to be life sustaining or life saving treatment. We wouldn't just do that to anyone, but it does obviously impact on the therapeutic relationship. It's very difficult, to have a rapport with someone. You can understand that, can't you? If they've been restrained by you and your team, they're not exactly going to engage in a kind of nice psychological rapport building session. So there are nice guidelines, as there are for most things. Do have a look. I think I've kind of said that there. Yeah, I'll skip past that one. So physical health issues, the main thing to be aware of, depending on where you work, is really around hypokalemia and hyponatremia, especially if people are purging or if they're not eating very much at all. What we've also seen is a lot of people with anorexia might be prescribed Sandoz-K potassium supplements because they've got poor nutritional intake. But they can sometimes misuse them, or they are sometimes used as an overdose method, because obviously potassium, very sensitive, very thin kind of margin with potassium before you are, life-threatening. I think the other thing to note as well, if you're ever having to make decisions with or even for someone, with low BMI, is that when you're very low BMI, your brain actually shrinks. And if you are taking in very little calories, there's a really strong argument to say that your brain is just not getting the fuel it needs to make decisions. So what can happen is that people might present superficially very well, might appear that they are kind of able to make decisions for themselves. But if you've got someone with a BMI of 13, 12, 11, 10, you have a really strong case there to argue that they do not have capacity to be refusing treatment. especially if that's life-saving. This is the resource. If any of you take one thing away from this presentation tonight, please, please, please look these up. If you work in a hospital, print them out, give them to your colleagues, save the PDF, share this with everyone that you know. Medical Emergencies in Eating Disorder. I think this is published by the Royal College of Psychiatrists. And it recognises that eating disorders are poorly understood by mental health practitioners, by A&E doctors and nurses. It's a very, very complex area. The benefit of MEAD is that it has a really great summary sheet and risk kind of profile targeted at different professional groups. So if you're a doctor working in a gastro ward, there's a sheet for you. If you're a nurse working in A&E, there's a sheet for you. If you're a parent of someone with an eating disorder, there's a sheet for you. And this really helps us just to get the basics right around electrolyte monitoring. As it says, medical emergencies in eating disorder and preventing them from getting worse. It was previously called Marzipan. I think they updated that. But it just gives you an idea of the kind of checklist that you might do, the things that might be considered high risk. So if you're an adult with a BMI less than 13, have you had recent weight loss, little or no nutrition over the past 5 days, acute food refusal. Some of you may have come across the term refeeding, which is refeeding syndrome is if someone's not eaten for a very long time or had very low nutritional intake, there is a risk that if you kind of introduce food too quickly, that can actually overwhelm the body and actually be a risk itself. So you have to build up very, very slowly. This would normally be overseen by a consultant gastro doctor in collaboration with a psychiatrist. But it's really important that we are aware of this so that we can consider it and make sure that we're not causing more harm through trying to do good. And then again, talking about ongoing management, are you collaborating with psychiatric staff? Most hospitals will have a liaison psychiatry team. Are you aware of how to look out for these other things like purging behaviors, falsifying weight, disposing of feed? Falsifying weight, it's not uncommon for people to put weights and things in their pockets so that they appear heavier, which again can give that false sense of progress and recovery. Just some critical perspectives that we're going to round off with. So some of you may have heard of James Downs. Now, he's very active on Twitter. He has an eating disorder himself, but he also works actively with the Royal College of Psychiatrists. He actually contributed to the MEAD guidelines that I just mentioned. And he's wrote a lot of papers about his kind of lived experience. And I guess one of the things that we know happens is that eating disorders are kind of not recognized as much in men. They are less common in men, but they're also less able to be picked up by professionals. And he's kind of recounted occasions where he's gone to seek help and he's received some really inappropriate comments. They said, "Oh, you've got a great physique," when actually what he was saying, this was the result of eating very little, over exercise because of anorexia, which was quite severe at that time. So he's quite a strong voice. Would recommend looking him up on Twitter if you're interested to hear more about this. Some of the things that we are encountering more and more, terribly complicated ethical issue. You might have seen the headlines, but some people with anorexia are being given palliative care rather than life-prolonging treatment under new NHS guidance. And people tend to fall into two camps with this. You've got people that think the idea is absolutely abhorrent, and you've got people who maybe take a more pragmatic approach that if you have worked with someone for 10, 20 years and they are not getting better, quite a clinically detached arguments around resources and who's deserving of treatment. Now, my personal view aligns with the Royal College of Psychiatrists here. They've been very clear that anorexia is not a terminal illness. It's a serious mental health condition with a higher mortality rate than other mental illnesses. But I think we feel it's a slippery slope if we start introducing palliative care for psychiatric disorders. Where does that end? In my view, the way I was trained is that every psychiatric condition is recoverable from. I think a big part of the role of a mental health nurse and a psychiatrist is to instill that hope that people can get better. You lose that hope in your darkest moments, and actually that's when you can give up. And I do not think it is ethical for 1 minute to take these very, very unwell, sick people and say, yeah, okay, let's stick you on palliative care. Because again, like I said before, if your BMI is that low and you are that impaired, I really don't think you can make capacitous decisions about your right to die. So I feel quite strongly about that. But I think it's something to watch out for. I doubt that any of you will be involved in making that decision, but I think it's something we're going to see more and more of in the media. And I do think it's a slippery slope. At what point do we then decide, oh, well, let's go in and start calling people with dementia in care homes to make space for bed blockers? You can see the similar arguments there. And I think when we start making judgments about who's got the right to live and who's got the right to die, we are stepping outside the bounds of medicine, in my view. But I'll get off my high horse there, and we'll just round off with some myths and a few of the other guidelines. Again, these myths have been perpetuated sometimes by media, sometimes by the way that things are portrayed. Perhaps a myth that eating disorders are just a faddy diet gone too far. Definitely not. Pure psychiatric disorder. Eating disorders only affect young women. As we know, it's kind of on the rise in men and potentially more serious because it is under-recognized. Eating disorders are a lifestyle choice. It's not about people wanting to emulate models or things like that. Yes, younger people are susceptible to the impact of social media, beauty standards, etc., but that is very separate to an eating disorder. That may well be the early stages of it, but it then becomes kind of clinically significant. Again, this myth here, I think, backs up the argument I was just making. There's this myth that no one recovers from an eating disorder. You've got it for life. If we can intervene early, people can recover. But I think we need to be doing more around early intervention, timely referrals, etc. And the last one there, as I think I've kind of got across as well, you can't tell that someone has an eating disorder just by looking at them. By the time you can tell, they've had that for years and years. And people with bulimia might actually look pretty consistently the same as well. They're not going to have that ill look, but perhaps, with their teeth over time, as I mentioned. So useful things, all of you tonight, go and download Mead, share it with your colleagues. That's one bit of homework that you get in, and do have a look on Beat. It's very helpful for patients, relatives, and professionals as well.